please help spread the message of frequency-specific microcurrent by clicking on the like button. You can subscribe to us on YouTube or any podcast app. If you have any questions, please leave them in the comments. You can find the podcast transcription at frequencyspecific.com, as well as more information about frequency-specific microcurrent.
How was Philadelphia?
It was fantastic.
You're doing hockey?
Yes.
Yay. Did we win?
All the way to the finals, lost in the final, but being second in the nation's not a bad title for these girls.
Oh, it was with the girls. My gosh, really? How exciting.
Super exciting. Yes. So it was like a work parenting trip.
Oh, good. Your work got there.
I was going to say it matches perfectly with Raynaud now in the background.
There you go. I was so far behind this year. I ordered them online without ever seeing them in person. I had no idea they were that big or that heavy. And
I'll just bring this closer so some people can see. You can imagine this is glass on a very heavy base. And I don't know if you can just see how beautiful it is.
all the layers and all the colors. When I have lectured in the past at meetings or homecomings or symposiums or whatever, they give you this little chintzy piece of paper on a frame, or sometimes it's framed and sometimes it's not.
Yeah.
And so pretty soon you have them on your wall, and then what? So I decided when we started doing the advanced and symposium and giving out speaker awards, that I would give out things that people would enjoy looking at.
Yes.
And it's a challenge now, because it's been what, 21 years that we've been doing, 4, 5, 6 years we've been doing the advanced, but this first symposium was in 2003. And that's when I started giving out awards. So it's really hard to find something new. So I'm so glad they turned out really good.
It's beautiful.
Oh, goody.
It came yesterday, and I was going to text you. I thought, no, I'll just bring it on the podcast so you can see it, and you can see the joy that it gives people.
Yay. I'm excited. Do you have a theme?
I've learned to not get too attached to my themes. So
Okay.
I do have a couple topics that I would like to bring forward, only because of all the people that are walking into the clinic in the last 2 weeks with these things. So I feel like there's a message that needs to be delivered.
No, the award is what made me think about what I've been, because if you look at that, it's in layers.
Yes.
There's some green and there's some blue, that would be us, and there's some white and there's clear, and there's layers of stuff. And we've had conversations before about treating frozen shoulder, and how it's pretty much a slam dunk. Yeah. So lady came in, she's 71 or 2 in there someplace, and she had a fall where she broke her left humerus.
Okay.
And jammed, like she tripped over something in the grocery store, broke her left humerus and jammed her right arm.
Okay.
10, 12 years ago. And she said, and from the start, they told her it was just frozen shoulder, and in a year or so it would get better. That was 12 years ago. And now it's classic. There's just no motion. So I treated it twice, and then sent her with a note to her GP to say, please take an X-ray and an MRI of the shoulder. And the X-ray shows no cartilage, bone spurs everywhere. And it completely changed my treatment, because frozen shoulder has to do with the subscap, the joint capsule, and maybe partial thickness tears in the back.
Yeah.
When you've got bone spurs, no cartilage, inflammation in the bone, and she's in her 70s, so I use 217, which is that really hard kind of calcium.
And what is it again? It's There's a word for the team.
Oxalates or ankylosis.
Yes. Okay.
And it's like the next step after 91 hardening, at least in my head.
Yeah.
That's how I use it.
Me too.
So we did that in the connective tissue to help soften the bone spurs.
Yeah.
But then I treated the bone. There's no cartilage.
Right.
So I treated the bone for inflammation.
And did you use like 59, 39, 783?
Mm-hmm.
Yeah.
59, 39, 783. There's a little bit of marrow down there in the humerus, but not the humeral head.
Yeah.
And just inflammation in the bone.
Yeah. And
necrosis and inflammation in the cartilage. And it's what we were talking about in the supine cervical practicum, in all of the practicum things. You treat the underlying cause, and the brain says, oh, thank God, I can relax. So that's what happened. It didn't increase her range of motion much, but she said, look, it's so much looser.
Yeah.
And so the x-ray, that's one of the layers, is FSM is an adjunct. So her insurance wouldn't cover it if I ordered her x-rays. So I don't have any trouble being part of a team that co-treats her.
Right.
So her GP said, oh, sure, ordered the x-rays and put in a request for the MRI.
So I'm super excited.
Yeah.
Because like always, you have a tendency of just jumping into my brain because the theme or my target place I wanted to go to topics were joints, were arthritic and joint replacements.
Yep.
So I want to talk about your frozen shoulder for a second, because like you said, true frozen shoulder, how most of us think of it, is muscle based. The muscles are tight. There's adhesions in the nerve. There's adhesions in the capsule, blah, blah, blah.
Tissue.
Soft tissue. We don't think about the bone. And I'm not sure what led you to, if it was just your physical exam of that hard end feel or just what it felt like.
I treated it twice and it didn't change at all.
Okay.
That was the decision making. It's, yeah, this isn't working. And if it's going to work, it would have worked by now. So let's look inside.
And I think that's a really valid point to talk about. So for the practitioners that are listening, we have that dogma of it never not works. So you're missing something. And that's what makes you a great practitioner, is after 2 treatments. And if you're throwing everything on it that you think is there should be some change, whether there's increased range of motion, pain reduction, something. But after 2 times and nothing's budging, we're missing something. And imaging helps tell the story.
Yeah, there's layers. And that's really a good point. The fact that it never doesn't work.
Yeah.
When it doesn't work, it means you have to look for what else is there. And
I think I was telling you about the story about I had a woman with a low back issue. And after 2 treatments, again, pain either stayed the same or got worse.
Oops.
And I'm like, we're missing something. So get an MRI, and it helped paint the story, because I'm only as effective as the information that I'm given, right? Obviously, the patient history and the story the patient tells us, but sometimes we do need that imaging for the objective measure that, and to no fault of the patient or the practitioner, there's just something that's being missed sometimes.
And we were telling stories a while back, probably at the advanced. My first year in practice, second year in practice, this lady came in with low back pain. And it had her bend forward, didn't change, bend back, it didn't change. And then I said, wow, you look really good. You've lost weight. She said, yeah, I lost about 20 pounds in the last 2 months. What kind of diet are you doing? Oh, nothing. Okay, I'll treat your low back. So I treated the facets and the discs, and I said, I need you to go check with your GP and let's do some imaging. And she had colon cancer. There was another patient, similar story. Lean forward, lean back, no change. Her MD had her on Vicodin, or Tylenol 3. And she came to me and I treated her once, no change. Treated her twice. She was in her late 60s, no change. And I said, you need to go back to your GP. And the GP said, no, it's just low back pain. You keep taking your Tylenol 3. She came back to me and I treated her and I said, this is not your back. Something's not right. She wasn't losing weight. There was no thing, but I typed on letterhead a note to him and said, I am seeing Mrs. So-and-so, and she has low back pain that appears to be non-musculoskeletal. She's 67, has an intact uterus and ovaries, has a family history of cardiovascular disease, and has not had a colonoscopy in 12 years. My medical legal position would be more secure if we had some imaging to confirm that she doesn't have something more serious. And 2 months later, she came back and she said, I think you saved my life. I have lymphoma. That wasn't even on my differential. I was thinking colon cancer, uterine cancer, aortic aneurysm, something.
Right.
Lymphoma?
Wow.
Yeah.
But the map and the pattern recognition that you have that leads you to, again, you don't need to be able to diagnose something, but it will give you the steps necessary to be like, I know what it's not. And it's not this.
And 10 out, something's not right.
Exactly. Yeah. So that's amazing.
That's why the core is overwhelm. And we deal probably 20% with pattern recognition, but the advanced, especially the whole first part, is pattern recognition.
Yeah. Yeah.
That's the thinking part.
Going back to joint, frozen shoulder, I'm going to try to keep steering the boat back to joint stuff, joint pathology. Joints. This was like FSM core class 101. It's never the muscle. What are you talking about? It's always the muscle. This is what my bread and butter is. It's the muscle. I only treat muscles. Now you're telling me it's not the muscle?
Right,
Like
sorry.
an existential crisis moment for the manual therapists in the room where they're just like, great, now what? But when you think about the muscles are reacting to something, the muscles never just get tight because they do. They are contracting in response to a stimuli. Always. So when, again, I'm going to go to the shoulder for a second. So I had a patient who's got frozen shoulder, like, how is it phrased? Frozen shoulder like symptoms.
Is that a thing?
Apparently.
Okay.
With arthritic changes. Again, verbiage. I've actually had 2 patients with arthritis in their shoulder this week. That's so funny. But anyways, both cases, the muscles are responding to the pathology in the joint.
Yeah.
So there's 2 ways of looking at it. There's a way of thinking, of course, the muscles are going to be tight because they're in response to what's happening in the joint, and we can't put tissue back that's not there. However, we can definitely treat the muscles that are tight and are acting in an improper fashion. So you get muscle guarding, you get splinting, you get muscles that are trying to do the job of another muscle. And there's a lot you can do with that. Even though you're not technically putting cartilage back in the joint, there's a lot you can still do. So you have a lot to say about this statement.
Just one word, an improper fashion. In my world, they're not behaving in an improper fashion. It's inconvenient because it messes up the range of motion and the function.
Right.
But they are behaving in such a way as to protect whatever it is the brain, the cerebellum wants them to protect.
Right.
So they're behaving perfectly.
Sure. Good listeners.
Exactly what they're supposed to do. There's a bursa that's stiff and scarred down. There's inflammation in the cartilage. I can protect that.
Yeah.
I can keep it from moving. Yes, sir.
Yeah. You're right with that verbiage for sure. It's not It is inconvenient. And from a biomechanical standpoint, it's a disaster, but they're good listeners. So the rotator cuff is a great listener. It's going to do whatever it can do to keep that humeral head in the socket the way that it wants to avoid the bone spur, the painful bone on bone, whatever that is. And these are the conversations that you have to have with your patient. Like, I'm not going to cure your arthritis, but I can definitely help with the function and get the shoulder moving and behaving in a way that is going to be much more comfortable for you.
Yep. And then, speaking of layers,
Yes.
we can stay with the joint, but at some point, if the patient has arthritis in multiple joints, that means, to me, not just to me, according to the literature, the patients who have terrible looking arthritis and no pain, like you look at the x-ray of the joint and let's say their low back, and you look at that and you think, how is he able to walk?
Yeah.
Terrible arthritis, but almost no pain. The same day, somebody walks in with really good looking x-rays and terrible low back pain. And the literature says the difference is, are you healing with inflammation or healing without inflammation? Also, it sounds like you and I have had very interesting
weeks, days or whatever. Yes.
Yeah. One patient came in, she's about a month ago, and arthritis in multiple joints, pain level out the roof. And I treated her, got her down from a 7 to only a 3. Her low back is killer. Her neck is killer. Tell me where you lived. And looked at her timeline. And I said, I will buy you lunch if your mold report is negative. All her mold results came in and she's positive. If the threshold is 0.8, she's at 2.1 in every mold species. So the mold turns down, it's an infection, turns down the vagus. The vagus has as its job to suppress inflammation. And it's so we can treat your low back. You can use anti-inflammatories. They have her on meloxicam. But until we get rid of the mold, this is like bailing out a boat while somebody is still shooting holes in it.
Right.
So it's layers.
Yeah.
They have arthritis. They have multiple joint inflammation.
Yeah.
And then you come to ask why. If you fall and you jam it, that makes sense. You get a bone bruise, it gets inflamed. But is it possible to get the train back on the track where you wanted it?
No, because it's going in a good direction anyway, so we can organically go that way. Yes.
Yes.
I think it's the point of never stop looking. So you get a diagnosis, shoulder arthritis. Okay. Does the pain match the imaging? Does the pain match the assessment, the exam? Like you said, sometimes you get imaging that is so scary and the patient's, I'm fine. Like me, I have no disc space. I'm fine. I feel like I wish I never saw what my x-ray looked like.
Yeah.
So yeah, it paints a story, but it's also, don't get complacent and don't stop looking for other things. So like you said, how you went down the mold route, of course, that's mileage on your part, but that is one of those stable states where, like you said, you could treat and give the best adjustments and do the best manual therapy, but you're never going to close the case completely because there's this underlying factor that also needs to be addressed.
And it's why at the advanced, it's all your fault. You're the one that said there is no separation between a visceral and a physical medicine track. I had an artificial one for 8 years. And the fact of the matter is that our stable state, we have physical medicine in the afternoon. We have a lot of visceral medicine in the afternoon because physical medicine is our bread and butter with FSM. It's so easy.
Yeah.
And I think the advanced practitioners benefit from knowing when it doesn't work, why it doesn't work.
Totally. Like I said, no one's scope of practice is going to be like encompassing everything that we see in like the functional medicine track or the visceral track, or however you want to split it apart. It's the knowledge of knowing what your limitations are and what you're working with. So I don't even want to say limitations, but I love all the knowledge. It's so funny going to Jen Sosnowski's talk on pandas. 2 pandas patients pop up.
No way.
Yes.
Yeah, I've got one coming in next week.
So it's, again, pull up the talk, and am I going to treat her pandas with all the supplements and stuff that Jen does? Absolutely not. I'm going to refer them to Jen, but it just gave me the knowledge of some of the things that I'm going to be working with. It's putting things on the radar that were never on the radar before, things to look out for, the emotional behaviors that I had no idea about when these kids walk in. So just invaluable education to help with the pattern recognition so you can help the treatment trajectory.
Yeah, it is just so much fun to watch.
Yeah.
Practitioners start where they start and then see where they end up 10 years later. Those of them that where FSM suits the way their mind works and
Totally.
the practice model and all of the things that have to fall together to get somebody that stays with FSM for 10 or 12 years.
Yeah.
And listen to the conversations at lunch. It's so amazing.
I know it is. Speaking of conversations, we have quite a few questions coming in already, and there was one that was emailed to me that I want to talk about too, but let's just get to a couple of them. So the very first one looks like there's a couple questions there, but what is the possible treatment for restless leg syndrome, which makes it difficult to fall asleep and sometimes even wakes up at night?
We used to treat restless legs with just 40 and 10, and that was pretty standard. And as time has gone on, I've become curious as to whether or not there's more than one cause of restless leg. The legs just get twitchy. So is that 40 and 10 just inflammation, or is it 81 and 10? Is it increase in tone because of loss of descending inhibition? Is it the position of your neck when you sleep? What does the physical exam look like? What are your knee reflexes like? What's your Babinski? How many beats of clonus do you have in your foot? Restless legs is what you call it when your legs twitch at night. It does not answer why do they twitch. I had a patient that used to get leg cramps every night, and he took Chinese herbs. And for him, it was when he had sugar at night, the leg cramps were worse. That means it's central, not peripheral. So I'd start with 40 and 10, try 81 and 10, and do a physical exam and see what their neck looks like. Maybe complete metabolic panel, find out what their potassium and sodium levels are, find out what they eat for dinner and dessert.
Interesting.
Find out whether or not they sleep with a pillow. Is their neck flexed? So if you have a little teeny bit of stenosis, but you love your pillow, so you sleep on your back and your pillow does this with your neck. Some people wake up with their hands numb. Maybe some people wake up with restless legs. I don't know. So I get all these emails about, what do you do for X? And it's, what's the sensory exam? What's the range of motion? What's the accident history? What's the reflexes like?
Number 2 of the question, how can we help in Raynaud syndrome? Does quieting down the sympathetic make sense? Oh, I have a lot to say about this, but I'll let you start.
No, I'm going to say this one's yours.
Raynaud's, as I have learned about, there's primary and secondary Raynaud's. A lot of the Raynaud's that we see are secondary from an autoimmune disease.
Oh, that's interesting.
Very interesting. And I learned that from a really brilliant rheumatologist at Stanford. I myself had Raynaud's, and I say had because I haven't had an episode in 2 years since I started treating my vagus.
Yep.
So Raynaud's, like I said, I would try to find out if it's primary or secondary if you're battling autoimmune, because the Raynaud's is going to be triggered from an autoimmune flare. And when that happens, treating the vagus on a continual basis is extremely helpful. And of course, there's triggers here and there, like shopping carts are usually a big one for people. So a lot of times I just wear mittens in the store, especially if it's cold, to just avoid a flare. So I think a lot with Raynaud's is patient education, and not to scare them into doing like an ANA panel, but definitely asking if there's been an autoimmune panel done or if anything else has flagged that you can correlate the two.
I hadn't even thought about it as autoimmune. I think about it as a sympathetic vagal or sympathetic parasympathetic balance where
sure.
the sympathetics win. Then I would go looking for what's turning the parasympathetics down or off in stress and trauma.
So we're getting to the same areas anyways, but
Exactly.
the autoimmune panel was interesting to note or to think about. And again, it's going back to what you were saying before. It's like bailing out a boat and shooting holes in it. So you could treat Raynaud's all you want, but if there's an autoimmune driver behind it, it's good to be aware of what you're dealing with.
And the connection between autoimmune disease and the vagus is it's not possible to get an autoimmune disease if your vagus is operating properly.
Totally.
And in the core this year, it was really a little scary. We had a rheumatologist in the room, and she explained the thinking in the rheumatology community that you have autoantibodies circulating. Everybody has them.
Yeah.
And then sometimes it just turns into an autoimmune disease. And I don't think I got a straight answer out of what causes that. Oh, it just happens.
I think you and I are the same, where we don't accept that
Based.
answer when it's like, oh, it can just happen. Anything when I hear that or idiopathic, I put my detective hat on right away and I get my determined little scowl. I'm like, I'm going to find out why.
And I roll my eyes. Comes from space and jumps on you for no reason. Okay, let's go looking a little more. But the detective hat is consistent. Loss of smell.
Yeah.
Latent EBV.
Oral steroids helped for a while, ruined the immune system for a decade, and the sense of smell is still weak and unpredictable. Possible reasons for smell loss.
So
We heard all about this with COVID, but
yeah. And the sense of smell is based in the ethmoid sinus. Interesting thing about the ethmoid sinus is that it has one opening. It's the only sinus that only opens in the front. So right here.
Yeah.
I have no idea why mononucleosis or EBV would be involved. That's a whole nother conversation about EBV. It's like everybody would test positive. How positive are you for it? And why do some people have symptoms from it and some people don't?
right.
Steroids help for a while, which means it was inflammatory. My go-to would be, the first thing I do would be a urine mold test with real time. It's like the mold colonizes the mucous membranes in the sinuses. Usually it's the frontal and paranasal sinuses, but it doesn't take much for the mold to climb up through that little hole. And especially if it's aspergillus or penicillium, the airborne molds, ochratoxin, aflatoxin, everything except for the trichothecenes, the black mold, everything else except that has spores. So you inhale and that could carry them up there. So if the mold test is positive, I'd treat the ethmoid sinus and the capillaries and search around for why. If the mold test is negative, you'd have to find some other reason. But my first guess would be mold. I don't know about you. What do you think?
I'm at a loss. This is your territory.
Yeah.
Interesting. Okay, a couple more questions. Regarding the custom care protocols and the flu, if we are using the flu respiratory protocol, which is about 2 hours, one time per day, is it not a time we should be using asthma protocol, vagus protocol, et cetera? Wondering if they are opposite actions in terms of vagus and immune system.
Yeah, the flu respiratory protocol is the one we developed for COVID. I use it for all kinds of flu now because it's every virus we have. And it just really depends on what organ you put on channel B. The one that's in the custom care mode bank, organs plus brain, is heart, kidney, liver, lungs, and brain, which is what COVID hit in 2021. And now with long COVID, it's whatever organ the virus is still affecting the signaling. So you go in and change it, but asthma doesn't treat for viruses. It treats for inflammation and toxicity and spasticity, and it affects the bronchi, not the lungs. If you've got a virus, you don't want to turn the vagus on. You
Right.
want the vagus just to be quiet and sit there and wait until the immune system, you want the immune system really active, fight the virus. And yes, you are correct, Michelle. They are opposite actions in terms of vagus and the immune system. So you can run immune support if you want to run a separate unit. And these days, COVID has mutated to the point where it stopped killing people. The virus figured out that it wasn't a good idea to kill your host. For me, it was like getting laryngitis in 22. I haven't had it since. So it's pretty mild now. So the 2-hour program was for full on, what did they call the first version? Omicron was the last one, Delta.
Yeah, it's a great question. What was the first one?
I don't remember what initial it had, but that's the only one you need 2 hours a day. I use it for long COVID, and I just go in and delete some of the organs that are doing fine. And the small intestine is affected a lot now. Lungs, sense of smell, usually pretty good.
Right.
Weight loss, 20 pounds in 2 months with Louise. You have a patient with a 20-pound.
I think that was your story, maybe.
Yeah, that was it. The patient loses 20 pounds in 2 months without trying, no diet change. They're not on meds. They need to go see an oncologist.
Yeah. Is it all right to use vagus concussion and or arthritis or stress/emotion protocols on someone who also has cancer?
Once again, Harry used to use concussion and emotion. I'm not sure what stress is. And the reason I say cancer is inflammatory and metastasis is inflammatory. So you want the immune system really active. Harry used to run concussion and immune support and emotions. And because he was an osteopath, he adjusted the spine. So if someone has cancer, concussion and or arthritis, stress. I'm not sure what arthritis stress is about. Is that from somebody else's mode bank besides us? I don't know. So concussion, yes. Emotion, yes. Immune support, yes. And then treat the side effects of traditional cancer therapy. I don't know, the brain, the heart, some chemotherapy agents cause cardiomyopathies and arrhythmias. Cancer is a whole complicated conversation. We might be time to have Roger Billica back.
Oh, yes.
Yeah. So next year's 2025. The symposium has been happening for next year. It'll be 22 years. 2003 was the first one. That was amazing. And he asked me, okay, if I'm really careful, can I do a lecture on how to use FSM as support in a cancer patient? And it was an absolutely beautiful presentation. It's in the compendium that you can buy. And I've got to figure out how to get that searchable more easily, like by speaker or something. but because right now it's just in chronological order, so you have to know which year he lectured, and I can't even remember that.
Roger has such a unreal ability to take the most complicated, complex material so anybody can understand it, and not only understand it, but feel quite confident with their understanding of it. Amazing lecturer.
Yeah,
So lucky that he's part of our world.
it just exactly.
They said his one about taking out the bad and putting in the good, and it was just so simple, but it just made so much sense. And I'm going to just take the boat off the course for just a quick second. But I was treating a patient who had an acute disc flare-up, chronic condition, 10 years old, but you know how discs can be. It just takes the wrong flexion and rotation to trigger something. And of course has bilateral muscle splinting in the lumbar paraspinals, because that's just what those muscles do when there's trauma happening to the back. So multiple machines going, because we're treating the disc and we're treating all the other things at the same time. And Roger's voice is in my head about be careful how much bad you're taking away, and you got to put in some good. So a lot of vitality. It's doing exercises after the treatment so that patient isn't just jumping up with these muscles that you've taken the tension out that are still pretty much protecting it. So tons of 40 and 89, all these factors are coming at you. Whereas before FSM, you would just have your elbow in there and you'd be like trying to refund someone's paraspinals that were tight. Like, again, what's the driving force?
Yeah.
So taking out the bad, yeah, you want to take out the tension, but you also need to put in the good, which is the activation of those muscles to say, okay, I get it. You need to contract to support the area, but this is how we do it in a little user-friendly way.
And speaking of putting in the good, your preference for using 49 a lot. So that was the last 15 minutes or 10 minutes on this shoulder lady.
Yeah.
Was vitality in the bone, the periosteum, the connective tissue. And it's like the muscles got smushier. And she said, oh, that feels really good.
Oh, 49 feels so good.
Yeah, it was fascinating because I've never used it that way. It was a drive-by for me. So now I have Kim's voice in my ear. Where's 49?
I love it. And again, it's that community of voices that we all collaborate somehow. And you pick little pieces out of the most unsuspecting talks. Like, I'll never forget going to Mary Ellen Chalmers' talk years ago. And I almost didn't go because I'm thinking, what do I care about the mouth for? And when she was talking and just about, I think it was failed root canals causing chronic inflammation. And the way she had phrased it, if your body is spending all its time fighting this inflammation, this inflammatory process that's happening, it's robbing your body's ability to heal elsewhere. And I was just, everybody like, did we all just hear that? Let's all get x-rays.
3D cone beams.
3D cone beams, absolutely. And I'm violently texting all my dentist friends, like, did you know this? Of course I did. No, but we all need to know this.
And speaking of Mary Ellen, this year she talked about trigeminal neuralgia.
Yeah.
And I got an email last week sometime from a friend, and she said, my husband has terrible trigeminal neuralgia. And I said, where? And it's the forehead and the upper branch. And I went, no dental work, no virus. They said he's on medication for it, which makes him feel terrible, but the pain is intolerable. And I said, did they do a CT or brain MRI looking for a stroke? No, they said it couldn't be a stroke. And I said, has he had a stroke before? And she said, yeah, he's had 3 strokes before. And I said, this is a stroke in the pons, which is where the trigeminal nerve comes out of. And I had Mary Ellen's slides in my head as I'm answering that email. It had to be a stroke. It's because they did the angiogram looking for that vein that's pressing on the nerve.
Mhm.
That was negative.
Okay.
And it's layers.
Layers, yes. I want to just talk one more thing about Mary Ellen. I had grabbed her off to the side and we were talking because I am very proud of my TMJD slides. And I was telling her about it. And we were talking about clenching versus grinding. And I think that's an important, we always talk, do you grind your teeth? And people are always talking about grinding, but clenching can be just as problematic for neck pain, headaches, because they're in this, and there's a plethora of mouth guards out there. So I was asking her about which mouth guard she likes, and she said it doesn't really matter as long as it provides cushioning, whatever's comfortable. And I had asked her about the NTI, which is the nociceptive trigeminal nerve inhibitor mouth guard, which I had used and it had cured my clenching. And she's like, oh my God, no. And I was like, oh. I have to recall my PowerPoint because I had talked about that one. And she said it can just, because it's a little device that just snaps onto your two front teeth, because with that trigeminal nerve, there's a reflex that you will never smash your top two teeth against your bottom teeth. So it automatically unlocks. So in the night when you're closing, and there's a little shelf that's on the back of that appliance, that when you start to bite down, the inhibition comes on and your masseter and pterygoids automatically release and your jaw opens.
That sounds good.
Sounds really good. And she said it can be amazing, but it can only be used in the short term, because people who wear it for a long time, as you can imagine, if you don't have, what do they call it, occlusion, when you're biting down, it can cause your teeth to shift because they're open for so long.
We only wear it at night though, right?
Exactly. Yes. So for me, and I told her I had used it for, I think it was about 6 months until I left it in a hotel and never saw it, because it was so tiny, but it had fixed my clenching. Like it was enough training. And she said sometimes that happens, that sometimes it does work and you don't need it anymore. So I'm going to do a public recall on the NTIs. Use it only in the short term as per Most Amazing advice.
Being a patient is a really good learning experience. This is yay. All right, I'll get to the second question in a second. I think that muscles tighten and cause tension on the degenerative bone, which must cause pain. So I try to release the tissues attached to the biomechanics of the affected joint. I've been really lucky to prevent 3 clients' surgeries on knees.
No, but again, because I treat so many athletes, we always talk about the short-term play and the long-term play. The short-term play is always getting them out of pain. That is always what needs to happen first and foremost. And then the long-term pain. Now you're out of pain, that's super, but how do we prevent the pain from coming back? And I think muscle and joint is exactly that. Like, it's the chicken and the egg. Do the muscles tighten because of something and cause some improper tracking, which sometimes we see that with the knee? There's like a hip injury, which causes tracking problems, and then the knee gets affected because it happened in the hip. And that's when patients look at you like you're crazy because you're pointing to their hip, but I'm palpating they're like, I came here for knee pain. Why are you looking at my hip? I'm like, well, because it started there.
And for me, it's like the poor knee gets caught in between the arch of the foot, the ankle, and the hip.
Totally.
And
it's the middle.
Unless they landed on it and broke their patella or tore their ACL.
Yeah.
And this is for Debbie. Why are you not coming to London? Because we did the math. When you're dealing with a hotel and a city as expensive as London, the hotel by itself would have been $30,000, give or take a couple of thousand, plus our airfare, plus the hotel. And we had 90 days out, we had 8 people signed up. So usually my strategy has been, oh, people always sign up at the last minute, we'll do it anyway. But the hotel costs have gone up so much, I just couldn't take the risk for London. It was a 5-day core. Now, what we did was take the 8 people that had signed up, maybe you were one of them, Debbie, sorry, and send an email out saying, we're really sorry, but we had to cancel. We'll give you a full refund if that's what you want. Or you can use, so the first time people, well, and even the repeats, you can use your purchase to watch the core on video, because if you haven't taken the core in 3 years, it's different again. And then in Dublin, we're going to be at the National Training Center. So the cost for using that facility is minimal. And that's a 3-day practicum. So we have 1, 2, 3, 4, basically 12 practicums in 3 days. And we can review the core material, but it's like the ideal way to go forward, which is to watch the core on video. Although there's something magic that happens in a classroom with 8 different clinical licenses. And there's just magic. So we're doing the US core seminars in Troutdale,